Dear Chairperson and all the attendees, it's my great honor to be here to report the study on association of deployment depth eccentricity index on hypo-attenuated leaflet thickening that is called HALT after tower. I'm Yan Li, Director of Department of Cardiovascularology, Tangzhou Hospital. I'm from Xi'an City. I don't have any conflict, and analysis of a coupling of fluid and solid was done by Suzhou Peixin technology. First, background, epidemiology of aortic valve disease. As we know, global burden of disease data showed over 300 million people suffer from AVD disease worldwide. In China, at least over 25 million AVD patients, with an overall incidence of 3.8% increasing rate, and it also increasing significantly with age. So TAVR has become a key minimally invasive treatment for aortic stenosis, and with over up to now, maybe I think 20,000 annual procedure in China. The first report of HALT was seen at 2013, published in Euroheart Journal. This case posted TAVR CTA on 7 days, reviewed a crescent, just like here, crescent-shaped hypo-attenuating structure adhering to the process cusp located in the formal native left coronary cusp position. According to the VOC3 definition, HALT is visually identified increased thickness of bioprosthetic leaflet on contrast-enhanced cardiac CT. And according to the extent of leaflet involvement, it was divided in 4 grades. Some cohort studies showed the existence of HALT is independently related to long-term mortality. And according to the consensus EPPCI, HALT is a kind of a bioprosthetic valve dysfunction, may shorten the durability of valve and eventually lead to bioprosthetic valve failure. And a meta-analysis of 25 studies showed in patients with diagnosed leaflet thrombosis at follow-up, the risk for stroke or TIA was increased by 2.6-fold. And TCT 2022 also recommended HALT is listed as one of the 14 evidence gaps in TAVR field. So US FAD suggested all those risk clinical trial of TAVR should perform CTA scan of aorta after operation to detect the occurrence of HALT. So up to now, the mechanism of HALT was considered as a virtual triad. Hypocoagulability, endothelium injury, and blood stasis. And a small sample study with co-valve evolute THV confirmed that thrombus volume increased linearly with implant depth. And the in vitro flow model also found supraannular deployment resulted in a nearly 7-fold decrease in stagnation zone size. So according to this background, we started the part 1 study. We prospectively enrolled patients undergo TAVR from September 2022 to December 2024 in Tangzhou Hospital, altogether 104 patients. And we collect baseline information and aortic CTA data. And according to the inclusion and exclusion criteria, we finally enrolled eligible patients, altogether 78 patients, and divided into HALT, non-HALT group and HALT group. All the patients will get analysis with aortic CTA analysis, and we use cardiovascular CT analysis software. And the evaluation parameters is as usual. Post procedure, we scanned the CTA at 1 month after procedure. And first, we defined the bottom end of a THV framework was calculated as inflow end. And then, according to this plan, we measured the THV implantation depth and calculated DDEI. And DDEI means deployed depth eccentricity index. We calculated the difference of maximal depth and minimal depth. I think DDI will show the non-coaxial of THV. Baseline characteristics, we found no significant differences between hot group and non-hot group in age, gender, BMI, comorbidities, or laboratory parameters. But we found a THV size in patient with hot was larger, and oversizing was also greater. And analysis of aortic CTA measurement results showed the patient who experienced hot had a larger DDEN and a larger implantation depth. We can say these two groups, DDEN and minimal implantation depth is the difference. Multivariable logistic regression analysis showed that DDEN and area oversizing are independent risk factor for HALT after TAVR. And we also performed the ROC curve. The predictive value of risk factor for HALT. First one is DDEI. AUC is about 0.896 was the highest one. And then area oversizer. So we get a conclusion that DDEI was the strongest predictor for HALT. And then area oversizing outperformed perimeter oversizing. And the interaction between different factors and the DDEI on the influence of a HALT, we found there are no other group interaction between this parameter, but the DDEI was the only one to show the high risk of HALT occurrence. And 6 months clinical event follow-up showed that HALT increased the incidence of stroke and transient ischemic attack. And the 6 month follow-up result of ECG and echocardiography suggested that the patient who developed HALT had worse hemodynamic parameters, such as EF, left ventricular ejection fraction, and high RPG gradient and velocity. So we further to study the mechanism of HALT by finite element analysis that is called FEA. So FEA is a numerical simulation technique that discretize target region into geometrically distinct subdomain for localized and integrated mechanical analysis. So this method is well suited for investigating structural deformation mechanics like THV. So we choose one patient case. A female patient with pure aortic regurgitation had no obvious calcification and in native well. But after TAVR, Taurus Elite 29 millimeter valve was implanted, and then on 30 days we diagnosed HALT. So we can, according to the CT, we can see the very big thrombus at such as this at Leaflet. So we use 4 steps to get the simulation. Step 1, first aortic was extracted from preoperative CTA. And then engineering document of THV was some data was obtained from Peijia Medical, and then obtained the actual implantation position of THV from post-operative CTA. And step 2, we get a simulation of THV implantation. First, we mimic a positioning, and then release, and then contract and rebound. So we get this this figure. And we also established the two model. One is normal position, the other is higher DDEI. Step 2, we should fix the zone to simulate aortic wall, prosthetic valve, and fluid area. And this parameters is some from a computer calculation. And step 3, we simulate halt by creating THV leaflet partial opening. We can give specific boundary conditions such as flow velocity, aortic pressure, and intraoperative TE measurement. So we try to mimic the halt situation by this method. And step 4, create a fluid grade and perform mechanical solution. We divided this area into 4.16 million unit grade to give the analysis, including peak flow velocity, blood flow stagnation, max pressure on leaflet, and hydrostatic pressure and wall shear stress. So finally we constructed the velocity nepherogram. We can say the blood flow will produce the shunt after crossing the incomplete. This one is incomplete unfolded leaflet. We can say here is scoring effect on the new sinus was significantly weakened here. And at the turning point, here, the blood flow is significantly disturbed. And on the other side of a leaflet, we can see the blood flow velocity very low blood flow velocity disturbed, dramatic changes. And we also construct the pressure nepherogram. We can say after passing through the prosthetic valve, hydrostatic pressure decreased significantly. This is normal, but hydrostatic pressure around the incomplete unfolded leaflet is the lowest in the whole model. But on the other side, the surface of pressure at the turning point of the leaflet is the highest pressure. So it's quite different. So WSS contour showed the WSS at the turning point of leaflet was highest here. And the WSS at incomplete unfolded leaflet is significantly higher than that other leaflet, such as here, compared to these two leaflets. Here, the pressure WSS is highest. So compared with model 1 and model 2, which one is normal implantation, the other has a higher DDEI. We can say the difference, the velocity control, peak flow velocity increased and the stagnation volume also increased at DDEI group. And max surface pressure on leaflet is also decreased, and the hydrostatic pressure is decreased at a higher DDEI group. And WSS also increased significantly compared to normal implantation. And the blood flow streamline diagram showed in mode 2 higher DDEI group, we can say the streamline in ascending aortic become more disturbed. We can say the streamline quite disturbed. So according to this study, we can say increased DDI of THV significantly alter aortic root hemodynamics, include blood flow velocity increased by 2 millimeter per second, and the stagnation volume expanded by 28%, and the WSS increased by 9%. So we should pay more attention to reduce DDI during tower procedure to avoid hemodynamic deterioration, to reduce the incidence of post-operative complication. That's my all report. Thanks.